I'm just going to be very still.
If that's not a GIF, then you guys aren't doing your job right. Welcome to the Medicare Cafe. If you can hear me blink twice or bark twice if you're in Milwaukee, you're joined by your host. My name's Olivia Richardson.
And I'm Jalen Jackson.
And this is where we get on just a little bit early, sometimes to test the things and make sure things are running appropriately, but mainly just to talk about absolute nonsense. Unless you guys have any questions that you want to talk about, maybe you've watched previous episodes or you just have some questions you want us to address, we can do so. But no one's asked any questions. If you do want to shoot me a text message, this is my phone number. I respond. It is my phone number, so feel free to shoot me a text. You can also call me, but like if I don't know your number, I don't answer the phone because I'm a millennial. If you don't want to text me because maybe you don't want me to have your digits, then you can also chat with us, and we do read those live. So interact with us, be our friends, because it's a lot more fun when you do. Jalen, before we get started, we got 4 more minutes. We were talking about, so this actually, I love pre-chat conversations because oftentimes they're just chaotic.
They really are.
Which is how I thrive.
Of course.
So I've been watching on Netflix. My favorite thing was I asked a question, then I allowed nobody to answer.
Yeah, we still don't have answer,
I asked a question, I'm like, what are you guys watching right now? I need something light. I need something upbeat. Because I've been watching the Tylenol Killer on Netflix, which is wild. If you haven't watched it yet, do so. I am not a conspiracy nut, but I enjoy a good conspiracy. And this one, I'm like, I can't wait to discuss with people like what actually happened. So I haven't finished it yet, but just talking about like cover-ups and like not to give it away, the secret of the Tylenol Killers, and there may be something involved with a cover-up, but still really entertaining. We were kind of talking about things of like, we're kind of now, what typically like the JFK letters, not letters, but the whole like CSI write-up of that's recently come out, which was, has anybody talked about that yet? Like,
not really.
Like, it was like what, like thousands, like 15,000 pages. So like they were like, it's going to take months for anybody to actually read through this thing. That's all I have on that. But any good cover-ups, any good things that have recently come out lately that we would expect to be seeing at this point?
Yeah. So I think they're like the one that popped into my head, which is already out in the open, but we were talking about how like we're kind of due for another round of like exposés, like the Tylenol Killer, like, that happened when we were kids, and like all that kind of stuff from like the 80s and 90s should start like popping into the world now. So like the one that popped into my mind, there's a movie called The Informant.
Haven't we talked about The Informant before on this podcast?
I doubt so, because it's about the ADM lysine pricing scandal, which is not something that normal people find entertaining.
No. But they made a movie about it?
They did make a movie about it.
So some people find it entertaining.
Yeah, it was a huge expose, and it's a really funny movie because this guy that was an informant for the feds was just like a wackadoo personality, and like even though he was informing, he was also constantly lying to the feds and allegedly had millions of dollars stashed away on the side that no one, like he did genuinely help prosecute this price fixing scandal, but also just lied to the feds the entire time at the same time.
So that brings me up, who is that serial killer? Gosh, what a fun start to a Tuesday morning. Who is that serial killer that may have killed one person, but they ended up pinning like hundreds of murder cases on him because he kept lying to the police and saying, yep, I did that one. Yep, I did that one. And like all the evidence was there that like, no, he actually couldn't have possibly murdered these people. But the police kept like closing all these cold cases. Lee Harvey Oswald. Is that him?
That was the guy who allegedly shot JFK.
No, not him then. Something Henry Lee Lucas?
I can promise you he had 3 names.
So somebody don't look it up on a work computer, but fascinating. Good morning, Emily, my best friend. So it is, again, gosh, we can just get started on it. I'm like, I love a good story. I love a good cover up. I love a good like this is what it looks like.
Intrigue and mystery.
Intrigue and mystery. Just, I wish I had glitter. No, if I had glitter,
nope.
Nobody is safe. Welcome, guys, to the Medicare Cafe. We are in. Oh, I'm not blocking anymore.
Ooh.
Welcome to the Medicare Cafe. You are joined by your hosts. Again, for those of you who haven't been on for the last 5 minutes, my name is Olivia Richardson.
And I'm Jalen Jackson.
And today starts the first day of our Cross-Selling Symposium, which I think actually I go here. Yes. For today's the first day. I've only been doing this for months now, and I still can't figure it out. Cross-Selling Symposium. So all of you guys who weren't with us last week, what we're doing right now for the Cross-Selling Symposium is a thing that we used to do actually a few years ago. We haven't done it in the last couple years, and it used to be like an hour and a half training every single day for an entire week. We're not doing that. We're doing about less than a 30-minute training on this, but we are taking for the next 5 weeks, we are taking a product per week, breaking it down and telling you what kind of clients need to have it, what is that product even, how to transition into it, how to sell it, and then what even like down to the companies that we recommend to sell it. And so today, obviously, as you saw, today we're focusing on recovery care. And in my opinion, Shaylin, you let me know how you feel. In my opinion, recovery care is broken up into 2 sections. Recovery care is like an umbrella term. There's 2 different products: home health care and short-term care. That's what I would classify as recovery care.
No, I would agree. Just, making that distinction from a traditional long-term care product or some kind of hybrid product that provides that longer term, just something that's going to provide 1 year or shorter benefit time frame, and designed to cover that recuperative care following a surgery or a bad fall, or some kind of short-term need, or even just serving as a bridge between a short-term care policy and a long-term care policy, or allowing you a little more time to help transition assets or spend things down before you end up on Medicaid. There's a lot of reasons to look at short-term care, recovery care of some kind.
Exactly. No, I love that. And I think you kind of broke it down to 2 things. There's really 2 things that a recovery care policy can do. And remember, we call them recovery care products. Yep. These are products that are not meant to be long-term solutions or custodial style solutions like a nursing home. These products are supposed to be utilized for whenever the intention is for that person to get better and be able to resume normal life. So 2 ways that this works. Number 1 is a short-term care policy. That is when a person will be going into a short-term care facility. People get this confused with short-term medical. Short-term medical is like an underage, under 65. Short-term is like a major medical, but it has an expiration date on it. Short-term care is you're receiving care in a facility. Those facilities are usually in a wing of a nursing home, which gets confusing. Because nursing home coverage is not covered by Medicare. That's custodial care. That's basically your mortgage plus extra help. Short-term care means that you have every intention of leaving that and returning home. On the alternative, home health care is whenever an individual does not want to go into a short-term care facility, but they still require care more extensive than just going to the doctor every few weeks. It will help. Home health care will help pay for things like occupational therapy, speech therapy, different RN services, different medical services that are actually carried out by a medical professional. Neither one of these plans are designed to take care of the custodial part. So these plans the main purpose of these plans is not to pay for somebody to come in and give you a bath, cook your meals, clean your home. They're designed specifically for the medical side of this. And so a lot of people say, why is a plan like this important? Shaylin, you kind of hit on a couple things, but I want to clarify something first. When you're writing a plan like this, it's important to understand how Medicare does cover these services, because they do cover these services to an extent. And Shaylin, once I kind of cover how Medicare covers it, I want you to talk about like realistically what actually happens though. So keep in mind, let's start with home health care. The way that home health care is covered is that a doctor, basically an individual, has to have a doctor note. No, like I'm going to school. A doctor saying that this person is unable to do at least, in Medicare's view, it's 3 or more of their acts of daily living. 2 or more. Okay, so 2 or more of their acts of daily living, and the doctor has to have a continual 90-day plan of care, meaning that every 90 days, the doctor has to basically go forward and say, here's what the next 90 days is going to look like for this individual, the services that they need, the amount of times that they need it, and home health care. If it is going to be covered by Medicare, is covered 100% by Medicare Part A. So a lot of people will ask, then why do I need a home health care policy? We'll get into that one here in a little bit. Short-term care is basically does a little bit different. It's a little bit more outlined and has a little bit more, I'm going to say nuances, but more requirements in order for short-term care facilities to be covered by Medicare. First of all, an individual, in order for them to qualify for Medicare to pay for their short-term care stay, they have to have at least 3 nights in a hospital, not 3 days. The way that they go, that says you have to have 3 days in a hospital, it's 3 midnights. So you have to go, like if you go into a hospital on a Monday, you have to go Monday night, Tuesday night, Wednesday night, Thursday you're now now apply or now can get access to that short-term nursing facility. There's a little debate right now, and Shailene, you're going to know better than I do, of how easy or how many people will actually make it to that 3rd midnight stay. A lot of conditions will not allow somebody to make it to that 3rd midnight. The hospitals will try very hard to get somebody oftentimes to that 3rd midnight because they want Medicare to step in and cover the first 21 days of that short-term care facility. But we do oftentimes see it to where a person will leave the hospital after 2 midnights and then not gain access to have Medicare covering that short-term care plan. So, or short-term care stay. So, Shailene, why don't we talk about like the logistics of both of these and how does this actually play out with a client?
Well, so it depends a lot on the facility, right? So the big thing with the home health care
I
is...
want this pen. You talk, I'm busy.
Yeah, you play with the pen. That's
Thank
fine.
you. Adults are talking.
So the big thing with the home health care side is that, one, someone can't need full time. You've just discovered it's a fountain pen.
This is too much for me. I'm already dirty. Sorry. Please continue. I am distracting.
They cannot need full-time care. So home health care is only qualifiable as an event if someone needs 3 days or fewer per week of those home health care services. So it's kind of a part-time solution for someone who may need some extra physical therapy, extra assistance, things like that, but it's not an everyday solution.
It's everywhere.
Happens.
Sorry.
And
I made a mistake. Sorry.
The short-term care side, of course, is for someone who does need that round-the-clock care, that daily assistance, daily treatment for their recovery. And really, whether or not someone can get to that 3 midnights depends a lot on the facility because, yes, there are definitely facilities out there that want to help accommodate folks and get them that coverage that they need, but there's a lot of disincentives in the Medicare payment structure for that 3rd midnight to occur. There's a lot of facilities that would really love to put folks on observation status or keep them out of inpatient. That's a big clarification. You've got to be 3 midnights as an inpatient, not observation. Now, you can appeal that. There's a lot of talks about different protections for things like this, that you can appeal your observation status even after the fact. You can appeal whether or not those midnights should have counted towards your inpatient status, because if you do end up as an inpatient, you get those 3 midnights, then the hospital is much more on the hook because their payments as a hospital are not just based on that amount of care that they provide to you, but also things like readmission rates. So they actually have a disincentive in some cases from actually admitting you as an inpatient, getting you that overnight care, and then getting you into a facility. Because if you then become readmitted to the hospital within 60 days, it can count against their readmission standards.
I'm so glad you're here. It's very helpful to have you, Shailene. Let's talk a little bit about the short-term care policy and why somebody who is on Medicare should look into or at least be educated about short-term care policies like Aetna, GTL. We'll get into those recommendations here in a little bit. So what the biggest one that I hear when it comes to the short-term care, there's 2 things. You hit them on earlier. One is what I've been told to as a Band-Aid for long-term care, and the other one being like actually using the benefits as intended. So for being a Band-Aid for long-term care policies, the reason why a lot of people will do that is because more so for traditional long-term care, like your Mutual of Omaha's, like you don't see them as much anymore, but also for more of those hybrid products. When you are quoting somebody in long-term care, at least in the traditional sense, they have what's called elimination periods. Elimination periods is basically how long that person needs to be receiving that care before the plan will essentially kick in. The longer the elimination period, the cheaper the plan is. And the plans can get incredibly expensive. Expanding that elimination period tends to make those plans affordable to an extent. So a lot of people will do a full 1 year elimination period on a long-term care policy and then use that 365 days, because these plans, like you mentioned, are about a year. You can stack them, but these policies are designed to care for somebody for at most a year, 2 if you stack the policies. So they will use a short-term care policy for the year that they're receiving care from these facilities before their long-term care plan will actually start paying benefits. So that's kind of what we mean by a Band-Aid. It's kind of used as to stack with a long-term care policy so that a person doesn't have a gap in receiving coverage for the benefits that they're receiving. The other part, though, where I think oftentimes, especially more veteran agents who have more experience with long-term care, they don't understand the benefits of actually having the short-term care. Jalen, do you mind kind of hitting on the first 21 days?
Sure.
And then what happens after that, and how do these facilities react to day 22?
Yeah. So with original Medicare,
I'm gonna try again.
if we do get that 3-night hospital stay, 3 midnights, and we manage to stay in that facility for 21 days, we are very likely to get kicked out, because you're going to start seeing massive daily copays for that skilled nursing care. You're also going to get into a period where you're going to be reevaluated constantly for, one, is your condition improving? Do you still need that daily care? And is it still cost effective, basically, for Medicare to be providing that care? So looking at all of those factors, facilities start getting a little nervous around day 22, because they're looking at, can we continue to show improvements in your recovery? Can we continue to justify the care you're receiving on a daily basis, or does it maybe need to transition to home health care and part-time services? And how is it going to be paid for? Now, in some cases, a Medicare supplement, for example, will pay for some of those copays, and so it's not that big a deal. But again, they still have to show improvement, whereas the short-term care, the home health care, is going to provide for your care as long as you cannot complete those activities of daily living, to an extent, regardless of that improvement in your quality of life or condition.
Mm-hmm. So again, Jalen, if you're working with somebody, who are you seeing that you're working with that you would say, I think that you would be a good candidate for short-term care policy?
Anybody who has a little bit of money and they're really scared of losing it.
Yeah. Talk about that. Let's talk about like long-term care, because that's what a lot of people don't understand, especially where I grew up. We were all farmers.
Yep.
A lot of us we were all what we call land poor.
Mhm.
Like everybody invested their money into farming equipment, land, all that stuff. Looking at your house was crap. You lived, your car was
Threadbare
crap.
millionaires.
Yeah, exactly. Everything was crap, but you had a ton of assets.
Yeah.
Why should, again, when we're looking at long-term care, we're talking about Medicaid, talk a little bit about that.
Yeah, so I think the big things are it is such a cost to the entire family. So if grandma needs to go into the nursing home for long-term care, recovery care, whatever the case is, what we know from some studies from LIMRA, studies from a lot of other industry professionals, on average, if someone goes into the nursing home, they probably should have gone into the nursing home as long as 2 years ago, because there's a lot of that uncompensated, unqualified care going on at home, where we want to keep people at home. We want them to be well cared for. We don't want to send grandma and grandpa to the nursing home, and that's a good thing by and large. But we need help, because that's a lot of work for everybody involved. It very commonly has massive health impacts on the caregiver, and it is more likely that nursing home stay turns into a true long-term care situation the longer we wait to receive that care. If you have that slip and fall, that hip replacement, that other major surgery or issue that should be treated with recovery care, but because of cost, you end up staying at home, it's way more likely that your condition is going to exacerbate and you're going to end up in that long-term care situation for the remainder of your life. Whereas having something like a short-term care, a home health care policy, getting that care you need right off the bat gives you that chance to actually recover and no longer need that care without becoming a burden on your family financially, or just time-wise, becoming a burden on your spouse or caregiver, and just improving everyone's health overall.
Let's talk a little bit about the home health care side
Yeah.
then. When we say that, we talk about how Medicare does if a person gets approved for Medicare home health care. Medicare Part A pays 100% of that cost. So a lot of people's questions are going to be, then why invest in something that's going to pay them as well if Medicare is going to pick up that tab? So what I like to say is that keep in mind this home health care policy especially is an indemnity style plan,
Yep.
meaning that the company, the insurance company, writes the beneficiary, whoever they appoint that beneficiary to be, either the person that the plan's covering or somebody else. They give that money, a check in the mail to that beneficiary, and what that means is that they can use that money however they need to use it. And some of these plans will come with some pretty interesting riders and
Absolutely.
extra benefits to help pay for some of it. Some in some states, not every state, but in some states, these home health care plans will actually pay for more of that custodial, more of that actual style of care with like the making meals, taking a bath. But here's the thing. If Medicare is picking up the cost, you still submit these claims. Even if Medicare covers it, you can still submit the claims. You get the money and you can pay however you want for all the services that you want. And especially in some states, and all states will have this, but home health care policies have really sweetened the deal to where they have what they call drug reimbursement programs. Each company has one right now, but some of them will do a little bit different. In some states, and it's basically like for every brand name medication, you get X amount of dollars back per year. For every generic medication, you get X amount of dollars back per year. And those medications do not have to be linked to a condition while you're receiving home health care benefits. You can be as healthy as a horse and still use these home health care benefits through the drug reimbursement programs. And the cool thing about that is in some states, you actually can pay the entirety of your premium if you utilize the drug reimbursement. So you get all this coverage and it doesn't cost the individual anything out of pocket, or it costs them very little out of pocket, depending if they actually use these drug rebate programs. For the agent, I love this because whenever money gets tight and people start looking at their insurance coverage of like what can I get rid of? The last thing they're going to get rid of is the plan they're actively using. So they're not going to get rid of their Medicare supplement or Advantage plan. They're not going to get rid of their prescription drug plan. They're not going to get rid of their home health care plan because they're actively getting money back they can do it monthly, but at least every year they get money back for actually having that plan.
And let's talk about the sales tactic here. If you're selling home health care policies to your clients on a consistent basis, which you should be, I would say an agent doing a bad job, if you've got a good mix of business on the books right now, you ought to be placing minimum 10% of your clients with a home health care policy. Just based on law of large numbers.
Yeah.
And if you're sitting there every year, here's the deal. We know you have to collect drug lists every year. We know you've got to get set up for AEP. That's a great time to have those clients say, listen, give them a Ziploc bag and say, put all your prescription receipts in here. When we get together in August to update your drug list, bring in that bag of receipts and we'll help you submit the claim. And all of a sudden, they're being incentivized to bring that drug list in, which you need to be efficient during AEP because you're going to help them get a check for $600.
Gosh, such a good point. Let's talk a little bit about, I know there's a lot of things going on right now, like access to care is a huge concern. Can you talk a little bit about why short-term care facilities are struggling with finding free beds and talking about how home health care is looking to be an option for a lot of people and why that is?
Yeah, so I think there's a lot of factors at play. One, short-term care nursing facilities, they've been struggling for a long time.
Yeah,
For the
this
last
isn't new.
10 years, this isn't news. They've been closing down, having staffing issues. We saw a lot of them close down just in the past couple years because of some of the changes to staffing laws made by the Biden administration. Now, part of the big beautiful bill is that they rescinded those staffing requirements. So back to the pre-Biden era staffing requirements for nursing facilities, and that's pros and cons, right? So it's a little bit of potential cost reduction for those facilities, so maybe more facilities can stay open. But at the end of the day, it also means there's going to be less people in those facilities to care for patients. So, there's going to be changes to how many people they can actually handle in those facilities. And it's going to be harder and harder to find those beds, especially if your client is going to plan on depending on Medicaid. Though, if you've ever driven around rural Missouri or rural anywhere, you'll drive past a nursing home, and every now and again they will actually advertise on their
Mm-hmm.
little billboard outside, Medicaid beds available, but they're only going to dedicate a percentage of those beds to Medicaid patients because the economics just don't work to fill your entire nursing home with Medicaid patients. So having a plan like this, one, is going to give folks options and access. It's really not even about options anymore. It's just about access.
Yeah.
If you don't, the old adage, you've got to spend money to make money. Well, with this, you've got to spend money to spend money.
Mm-hmm.
You have to spend the money on a premium to pick up this short-term care, this home health care, so you actually have access to the care that you need, whether it's in a facility or a home health care agency. It's also just options. There's so many places that, maybe if you live in that rural area, home health care is not a great option because there aren't any agencies around. There
Right.
isn't someone who will come out to your house because of distance to the nearest agency or staffing issues that they may be facing. So again, it's just about having those options, that accessibility to the care that you need.
That's such a good point. Zach asked a great question. With the drug reimbursement plans that come with home health care, do carriers charge or increase premiums because of the amount paid in claims? Still have a hard time understanding how the carriers profit with these plans. They do not. They do not increase. Again, we've been working with a lot of these home health care policies. Well, actually, one of the first products I ever pushed whenever I joined senior marketing specialist was a home health care policy that doesn't even exist anymore. It was
Back in the
Kemper,
day? Yep.
National Reserve. What was it called back in the day? Kemper. But these plans don't go through massive rate increases, period. They don't. I have not seen plans go through. In fact, GTL a few years ago actually went through a rate decrease on theirs. So no, we don't see that. And honestly, Chandler, I'm sure you'll have more in the math and semantics to it. But the reason for it is that it's really cool. How do plans profit off these plans? How do carriers profit off these plans? Number one, it's an easy sale because it sounds really cool that you're going to guarantee, to get money back on the prescriptions that you use. The fraction or the amount of people who actually utilize the benefit are very, very low. So you get a lot of membership because it's a cool sale, but a lot of people don't actually take advantage of that membership. It's like the rebate program at Menards. I don't ever use the rebate. I talk about it. I will go buy the things knowing that I'm going to get my 11% back, and I never do it. So it's, again, a lot of people just don't take advantage of it, which is our jobs as an insurance agent to help people use those benefits.
Yep. It's also really useful for folks who do take a lot of meds, but you got to understand these are all plans that do still have underwriting. So if you've got someone who's taking 6 or 7 or 8 medications and actually could claim the full amount every year, they're likely to have some health complications that might make it a little more difficult for them to health qualify. Now, if you get someone on 1 or 2 meds, they're really not costing the carrier that much, even if they do claim that full amount.
Yeah.
Now, if their health changes in the future, no big deal. They make those claims and go on with life. But because these are underwritten products, it's not always that big of a risk for the carrier from the standpoint of having to pay out that full amount every year right out the gate because they are health underwriting these people. So there's a lot of economics behind that. And again, anyone who thinks that carriers make money just by collecting premiums and hoping they pay out less in claims doesn't understand, business at all, but definitely not the insurance business.
Yeah.
So, they're investing this money, getting returns on those investments, and that's how these things cash flow a lot of times.
A good reminder, though, of, when we look at loss ratios, when we look at things like that, understanding how insurance companies, how they make their money. I mean, it's all back of house.
Yep.
Insurance is a front. Kind of. So let's get, for the remaining time we have left, we have about 5 minutes. Let's talk a little bit about how to actually sell these policies. Hopefully by now you understand how they work, why clients need them, but oftentimes that's not enough to get you comfortable to actually presenting the product. So the biggest thing, number one, when it comes, you'll hear this every day of the symposium, it's all about your fact finding. 100% of cross-selling opportunities happen in the fact-finding portion of your appointment. So let's get into what questions can you ask that help you set up bringing up home health care or just recovery care. Yeah. What questions do you ask in the beginning to help bring up recovery care in the solutions part of your appointment?
Yeah, I think number one is just getting a clear picture of their finances.
Mm-hmm.
Is this someone who has just Social Security to live off of? Do
Mm-hmm.
they have a 401k, an IRA, something like that sitting around? And what are their plans for it? Now, this doesn't mean we need to, immediately try to roll them into a financial product or immediately try to sell them on a long-term care annuity or something like that. But, here's what we know for a fact. In a relatively low cost part of the country like Missouri, a nursing home with a private room is going to cost you $100,000 a year. Or
Yuck.
a short-term care policy is going to cost you, even pessimistically, $100 a month.
Yeah.
So the economics just make sense if you've got that money and you want to protect it, or at least mitigate your risk, downplay some of that risk. So huge opportunities just for talking about those finances, getting an idea of the picture. And here's the big thing. Things like long-term care, whether it's home health care, short-term care, whatever it is, that discussion is a family discussion.
That's a great point.
If they have kids in the area, if they have someone who's going to be that caregiver, if they ever need things, get those folks involved in the discussion. Get that, we used to run, I called them beneficiary appointments back when I was in the field. And I would ask folks, because way back when I started Banker's Life, like half of my appointments were with orphan clients that someone else wrote them a final expense. And I would say, hey, you've got so-and-so listed on your beneficiary on your, $5,000 life insurance policy. Is that still who you want on there? And if they said yes, great. I would say, well, do they know about that?
Mm-hmm.
Find out who that person is, whether it's the beneficiary on their life insurance, their kids that live 5 miles down the road. Find out who's going to actually take care of them. Find out who their power of attorney is. That's the person who's going to have to deal with the consequences of whether they buy or not, and they should be involved in that conversation. Maybe mom and dad don't see the value in spending $250 a month on a really blinged out short-term care policy, but if you live 5 miles down the road and you're like, mom and dad are not moving in with us, that's not going to happen. It might be worth $250 a month to them to help cover that.
I think that's important. It doesn't have to be the beneficiary buying, or the beneficiary doesn't have to be the person receiving the care, right? You could have, again, the kids, the adult children taking the policy out on mom and dad because that's what they wanted. Like, and again, if I've heard this 100 times, I've heard it 1,000,000 times, is I just don't want to be a burden to my kids. I don't want to be a burden. And so bringing that up and being like, I think one of my favorite questions was actually one that Dan Mangus, again, whenever I was peddling, I don't know what other way to say it, this product back in 2013, was the question that agents need to ask is, what are your plans when you leave the hospital? Because when you're you're not leaving the hospital completely taken care of, ready to go. You're leaving the hospital being sewn up, put back together. The recovery doesn't happen there. Are you aware how Medicare works when you leave a facility? And having them ask that questions and asking for a true answer. Like, you need to have a game plan because here are the statistics. Here's what's likely going to happen to you. Here's why. What is your game plan for that? The answer doesn't have to be a home health care policy, but you need to have an answer for that. And oftentimes you'll get, well, my kids will take care of me. My husband, my wife will take care of me. That's my favorite, my husband or my wife. And it's okay, well, my wife will take care of me. Okay, so your wife is going to be picking you up, taking you to the bathroom. You are twice her size, my guy. You think she's going to do that? Or do you really want your wife to have to change your bedpan? Do you really want your wife to have to handle that? Let alone your kids having to take off work and do it. So getting as detailed, because the point of this is, I don't like fear tactics. In any cross-selling, I don't believe in fear tactics, but I do believe in making them uncomfortable. Because if they're uncomfortable with their situations, that's the only way that they're going to be willing to change their situation. So making them truly aware of this is the reality if you don't have a plan in place. Are you okay with that? They don't know what they're asking for. You're exactly right. No one's going to ask you for this.
Oh, so-and-so will take care of me. They don't actually understand what they're asking that person to do. Because they've never been through it. Unless they had a parent that they took care of, they've never been through it.
Which a lot of them will.
Even then, like, you want to talk about rose-colored glasses, like, that's one of the, you block out the bad parts.
You block out the bad parts because, again, you were there in their final stages. They want to be that for you. So that's such a great point, because asking them, like, have you done this for somebody? Tell me about that experience. Do you want your kids to have to do that? Do you want your spouse to have to do that? Stories sell.
They do.
And especially whenever it's going to be easier if you're a husband and wife situation. I think that the wives will be much more likely, because, again, like, I love my husband dearly. Mother of no, he is not going to be taking care of me in the event that I am unwell. Like, I mean, like, I love that man to death, but unless it requires a wrench and some pliers, he's not going to handle it
Yep.
well. So it's asking the wives, what is the plan? Because you know your husband's not going to be it. We know that the average caregiver in America is a woman between the ages of 45 and 55. So they've likely been in a care situation before. They're not going to want to have to put somebody through that same situation that they went through.
And very likely may even still have their own kids at home.
Gosh, so true.
Yeah. So it really is a big discussion. And it's also a discussion of legacy, because you look at, if someone's sitting there in a house that they own and they want their kids to have that house, or want their kids to be able to sell it and do something with the money, or if they want that 401k or those annuities or whatever the case is to pass on to their kids, this is the number one way they will lose every penny they have.
Yes.
It really, really is. And it's an important discussion to have with folks, because if you go on Medicaid, there's a lot of states that do actively pursue Medicaid recovery. If the state spends $500,000, which again, that's only 2 or 3 years.
Yeah.
If they spend $500,000 caring for you in a facility, they will come after your estate. They will put a lien on the house. They will clear out those retirement accounts when you go through probate. Are there ways around that? Yes. Get to be good buddies with an estate wills and trusts estate attorney. That's a great idea. But also not everyone has the time for that. With so many people delaying care, like we talk about this all the time when we talk about med sup rate increases and why things are going crazy in the med sup market. Joint replacements and cancer, those are the two biggest things driving up med sups right now. It's also 2 of the big reasons people end up in facilities. So if you're talking to folks that are 65 to 69, this is a time critical decision, because they're very likely to have an experience just in the next 5 to 10 years that means they will need this kind of care.
I love it. Guys, that's what we have today for day 1 of the Cross-Selling Symposium, where we are talking. Oh, I do have to get into who we recommend, but we don't have time. It's 10:30. Call our office. In short, I can tell you why we recommend these plans. But in short, the companies that we recommend for home health care, primarily going to be Heartland and GTL. Those 2 plans mirror each other. They are, for home health care, they're almost guarantee issue, not quite, but they're almost guarantee issue. Go up to age 85, have daily benefits. Just call our office. But those are the 2 plans that we're going to recommend there. They do have the drug reimbursement program. And then for the short-term care benefits, oftentimes we're going to recommend both GTL and Aetna. We've told a ton of the Aetna short-term care benefit. The cool thing about both of those plans is that both of those companies is that one contract gets you a ton of ancillary products. You're going to hear Aetna talked about a lot. You're going to hear GTL talked about a lot, because they're one of the few plans that offer every one of the products that we're talking about this week. So those are the companies we recommend. Again, GTL, Aetna for short-term care, Heartland and GTL for home health care. Come talk to us. Call our office. We will let you know exactly what's available in the area that you're in. We're very transparent with contract levels to make sure you know exactly like what you can qualify for, how to get to the next highest level. And that's what we have today, guys. I don't know how to get to the ending slide. Nice AD in Christ. It's a button on here. No. I love you all very, very much. Thank you all for hanging out. Next week, we will be likely, I don't know what way I want to talk about next week. I either want to talk about home health care or not home health care. I either want to talk about hospital indemnity or final expense. So the jury's out. You guys, if you guys have a product specifically that you want us to go over, we'll be happy to do so. But ultimately, it's going to be recovery care, hospital indemnity, cancer insurance, final